Management of weight or management of obesity is actually in the core and the center of managing patients with type 2 diabetes. Obesity and excess weight contribute to the increased risk of type 2 diabetes and also contribute to the increased morbidity of the disease. And without treating the obesity and the excess weight, it's very difficult to see how we can actually treat diabetes and its complication. So there is no doubt that management of excess weight really take a priority in the management paradigm of patients with type 2 diabetes. So I think the first thing we need to highlight here is that all weight loss methods, whether they are lifestyle interventions, pharmacotherapy, or bariatric surgery, all had significant impact on glycemic parameters as well as other comorbidities related to diabetes and its complications. So they all work, but obviously they work to varying degrees. So most of the weight loss occur in the context of bariatric surgery. It achieves higher and more sustained weight loss than pharmacotherapy or lifestyle intervention, and the achievement rate of diabetes remission and the improvement in glycemic control with bariatric surgery has been shown in randomized controlled trials to be superior to pharmacotherapy, even when pharmacotherapy is used intensively. However, as I mentioned, lifestyle intervention and pharmacotherapy still have very important effects, favorable effects on diabetes in terms of glycemic control as well as its complications. Now, within the different lifestyle interventions, there doesn't seem to be any particular preference towards one diet or the other, although more recently with the direct trial, the very low calorie diet has shown a very high remission rate at 12 months in terms of diabetes, where patients managed to drop their blood sugars to below that cutoff for diabetes. And that are very impressive results, but we are awaiting obviously the longer term results. I think the way how we approach this topic needs to be quite sensitive and careful. Our job is to give the right treatment to the right patient at the right time. And if that treatment is surgery, then let it be. And if that treatment is lifestyle intervention, then it needs to be lifestyle intervention. So it's not about trying one treatment to replace the other. I do think, however, that all patients with type 2 diabetes deserve to receive intensive lifestyle intervention, which currently, based on the evidence available, should include very low calorie diet, as this might have major impact on their glycemic status and diabetes related complications. But we need to keep in mind, if this doesn't work or is not sustainable, we should not just leave the patient to wait forever. They need to go down the route of pharmacotherapy and bariatric surgery. But for some patients who have a huge body mass index, then bariatric surgery may be actually the most appropriate first-line treatment for these patients. So it's not about one replacing the other, but they are all complementary in terms of improving patient outcomes. I think the program this year actually includes reporting multiple trials, such as the Harmony trial, which I've just heard now. We also have the Camellia outcomes, we have the Carmelina study, we have the RISE study. We have on Friday the guidelines, joint guidelines between EASD and ADA. We also have the Pioneer study reporting. So I think there are lots of very interesting large-scale clinical trials that aid our understanding of the management of patients with type 2 diabetes, as well as adding actually understanding the mechanisms behind type 2 diabetes. And obviously all of that, in addition to that, there is also significant development in the Pioneer study, in which actually GLP-1 will be delivered already. So that's a new development that we look forward to hear more about.